So your slides are not visible.
I'm uploading the
Okay,
slides.
all right.
Thank you. Is the slides visible, Usha ma'am?
Yes, sir.
Is it moving, ma'am?
Yeah, I did move to this. Yeah,
Okay, thank you.
thank you.
Ashima ma'am has called me and said she's having a flight as of now, and she'll be joining shortly. So we'll wait for the other participants also. Is it okay, Usha ma'am?
Sure, sir.
Okay. Please let me know when to start.
So anytime you need,
Okay, at
anytime,
least
anytime it's okay. Yeah,
let's wait for some participants too.
sure. Yeah.
Yeah, thank you. Shall we start, Usha ma'am? It's 6:06.
Yeah, let's start.
Okay. So, good evening, everyone. AME proudly presents the master class for the evening. So, myself, Dr. Hari Prasad, Senior Resident Emergency Medicine, AIIMS Delhi, and our key patron, Ashima ma'am, is having a flight. She will be joined shortly. So, it's a wonderful learning experience through AME. So, without much introduction, we are going towards today's class. Acute hypocalcemia and hypercalcemia, which are very important ones. Mostly we'll be concentrating on sodium and potassium disorder, but calcium too is important. So we can go to a little bit of pathophysiology. So the calcium, 99% is present in the bone, and the rest 1%, 50% is present in the ionized form, 10% is bound anion, phosphate, sulfate, bicarb, citrate, and the rest of 40% is protein bound to albumin and everything. It is influenced by two things. One is hydrogen ion, that is pH, and protein. So when the hydrogen ion increases, as in acidosis, or if the protein increases, there will be increase in calcium. If the hydrogen ion decreases or the protein decreases, or that is hypoalbuminemia, there is decrease in calcium. So this is we should keep in mind. The normal serum calcium levels, various labs have various cutoffs. So, but general international standard, it is 8.5 to 10.5. And for ionized calcium, depending upon the unit, whether it is milligram per deciliter or millimoles per liter, again the value will change. But most of the should have millimoles, so we will go with the millimole part, 1.16 to 1.31. So which one is better, whether it is corrected calcium, total calcium, or ionized calcium? The studies found that in case of institution having ionized calcium, it is the best one to obtain because it is the gold standard. It is it is not affected by many other hypoalbuminemia condition or other problems. So ionized calcium is the gold standard. The problem with the corrected calcium is in this, the equation for the corrected calcium, that is 0.8 into 4 minus albumin plus serum calcium, does not hold good in very low hypoalbuminemia. So if you don't have ionized calcium, it's okay. Get the serum calcium level and albumin and connect and calculate the corrected calcium. Otherwise, please go forward with the ionized calcium itself. Hormonal regulation. Don't get afraid with this slide. We'll just simplify it. Just think of three things. One, there is parathormone and vitamin D and calcitonin. Calcitonin we will cover in the hypercalcemia part, but that is the third hormone. So the parathyroid hormone released from parathyroid act on three parts. In the kidney, it causes increase in calcium reabsorption and increase phosphate excretion. So net level will be increase in calcium and decrease in phosphate. So in PTH is inversely proportional to phosphate, while it acts on the GIT to cause calcium and phosphate reabsorption. So the net effect will be calcium and phosphate will increase. So vitamin D is directly proportional to phosphate. So just remember these two equations because it will hold when we go to the algorithm, we will come to know why it is. And the third action will be on the bone because it increased the bone resorption. So the active form of vitamin D is 125 hydroxy vitamin D produced from the 25 hydroxy vitamin D from the liver. So coming to the etiology. So we can, for the simplification, we can broadly divide the etiology as low PTH, high PTH, because there are various classification, various books. So I think the best one to go with this one, this classification, because it's little organized. So low PTH means that the PTH is suppressed, that is in hypoparathyroidism, and high PTH, in spite of there is calcium, if hypocalcemia due to non-PTH causes, which can secondly increase the PTH, that is in secondary hyperparathyroidism. We'll discuss the primary and tertiary hyperparathyroidism in the hypercalcemia part. Just remember, secondary causes hypocalcemia. So low PTH, hypoparathyroidism due to abnormal parathyroid development, that is DiGeorge syndrome, or destruction that is caused by surgery leading to hungry bone syndrome. We'll be discussing in a while. Radiation, infiltration conditions like metastasis, sarcoidosis, autoimmune conditions like autoimmune polyglandular syndrome 1, and reduced parathyroid function in hypomagnesemia. So here PTH secretion is, which is normally trying to increase the calcium, is insufficient to normalize the serum calcium in low PTH or hypoparathyroidism disorders. We can remember the causes as Madras mnemonic, that is M4 hypomagnesemia, metastasis, A for autoimmune conditions like APS1, D for DiGeorge syndrome, R for radiation, A for alcoholism, S for surgery, and sarcoid. Sarcoidosis is very important one because it can present as both hypocalcemia as well as hypercalcemia. So that's an important thing to note. Then hungry bone syndrome. So hungry bone syndrome means usually the body is suddenly the turnover has been increased. So there is sudden calcium uptake. So whenever the parathyroid hormone was there, it causes calcium increase by bone resorption. So suddenly if the suppression is lost, there will be increased uptake by bone. So there is bone formation or osteoblastic formation. So this connection can be lost in parathyroidectomy or sometimes in thyroid surgeries when inappropriately removing parathyroid, also in Cushing syndrome after curative surgery, or sometimes if we give just vitamin D for rickets. So these are the common condition, and if we come across renal tubular acidosis patients, if we acutely correct metabolic acidosis also, we can see some such syndrome, hungry bone syndrome, where there will be sudden hypocalcemia due to the acute shift in metabolic turnover. Next, coming to the high PTH or non-parathyroid causes. The first and most important will be vitamin D related. It can be deficiency, impaired production, action. So it can be nutritional, or it can be chronic kidney disease or vitamin D resistance. And parathyroid hormone deficiency syndrome, that is due to hypoparathyroidism. We will come to it in a while. And some drug induced and miscellaneous conditions like tissue injury causing, that is burns, sepsis, rhabdomyolysis, extravascular deposition, that is acute pancreatitis, osteoblastic mets, hyperphosphatemia, massive transfusion. The drugs can be remembered as CAP flag, that is calcium chelators, anti-seizure medication like phenytoin, phosphates like enema, laxatives, fluoride poisoning, because fluoride is found in toothpaste, So sometimes the patient can present with hypocalcemia. Then loop diuretics, aminoglycosides, and glucocorticoids. So CAP flag is the mnemonic for the drugs causing secondary hyperparathyroidism as the second part of the process. So to differentiate between hypoparathyroidism and pseudo hypoparathyroidism, just remember hypoparathyroidism is due to decreased PTH, while pseudo hypoparathyroidism due to increased PTH. So there will be increased PTH. This secondary hyperparathyroidism is due to mostly vitamin D related. So vitamin D is directly proportional to phosphate. So the phosphate will be rising, and there will be skeletal abnormalities. That is pseudo hypoparathyroidism. The rest all part will be same as hypoparathyroidism. In judo, there will be just skeletal defect, but phosphate will be normal. The core points from this slide is just these points. So coming to the relation of magnesium and PTH. If there is mild to moderate magnesemia, there will be PTH resistance. While case of severe hypomagnesemia, there will be reduced PTH secretion, as we have seen in hypoparathyroidism. The causes can be most commonly alcoholism, malabsorption syndrome, diuretic therapy, aminoglycosides. So if we have seen hypocalcemia which is not correcting with calcium, think of magnesium, and we should correct magnesium first. The clinical features can be remembered as spasmodic, that is spasm, perioral paresthesia, anxious or irritable, seizures, increased muscle tone, orientation problems, dermatitis, impetigo herpetiformis, and Chostek sign and cardiomyopathy. So there are usually two signs, that is Chostek sign and Trousseau sign. Chostek sign, if we tap along the facial nerve, there will be twitching of the perioral muscles. It's not the facial muscle. We should be more specific. That is just perioral muscle twitching. Trousseau sign, if we increase the BP to the 20 mmHg above the systolic BP, there will be carpopedal spasm. So these two signs can be elicited in hypocalcemia. The other long-term effects of hypocalcemia are this cataract. Then there can be basal ganglia calcifications, tooth deformities, skeletal disturbances. The skeletal disturbance shown is from judo hypoparathyroidism. There will be dorsal radial abnormalities and kind of obesity. So we can simplify our discussion as in this algorithm. So the step one for hypocalcemia is always double check the hypocalcemia is present or not. Ionized calcium, if present, that is the gold standard if we can try. Otherwise, the corrected calcium should be done with albumin. And next, go for the, once diagnosis done, have to find the cause. Clinical clues from history of surgery, then can be pseudo hypoparathyroidism, drugs, CKD, pancreatitis, any family history of some problems. So these all should be looked into. So the lab parameters, we should go for phosphate, parathormone, magnesium, vitamin D, and creatine. So the first thing will be hypocalcemia, confirm diagnosis, look the PTH level. The PTH is low, hypoparathyroidism, Madras causes, hypomagnesemia, autoimmune causes, Dijo syndrome, radiation, alcoholism, surgery, sarcoid. If normal, again, think of hypomagnesemia because some condition PTH evaluation may be normal and there will be concomitant other electrolyte abnormalities also. Then in case of a mutated calcium sensing receptor. This calcium sensing receptors are present both in the parathyroid as well as the kidney. In the parathyroid, it gets stimulated when there is hypocalcemia, and in the renal, it gets stimulated when the calcium level is okay. It will inhibit the parathormone secretion. And if the parathormone is increased, go for simultaneous phosphate and vitamin D levels. If the vitamin D is low, it can be vitamin D deficiency. But if the calcitriol is also normal, then it can be vitamin D resistant rickets. If it is normal, look for other causes. The phosphate, if it is increased, we should look for creatine. The creatine is increased, chronic kidney disease. If it is normal, pseudo hypoparathyroidism. So PTH, calcium low, PTH increase, phosphate increase. We usually think of increased creatine. If not found, pseudo hypoparathyroidism. If phosphate is decreased or normal, look for other causes. Therapy, when the patient is symptomatic or if there is ECG changes like prolonged QT interval, as hypocalcemia causes QT prolongation, hypercalcemia causes QT shortening. QT prolongation, symptomatic Trousseau sign, Chaucer sign, or acute decrease less than 7.5, or ionized calcium less than 3 mg per deciliter. And this is 3 mg. In all such cases, IV calcium is recommended. For mild symptom or chronic hypocalcemia, just oral calcium supplementation is enough. So calcium, there are many forms are there. Calcium gluconate is the most commonly available. We can give 1 to 2 grams of calcium gluconate, 90 to 180 elemental mg of elemental calcium, means 1 ampule has 10 ml, that is 1 gram, or 90 mg of elemental calcium diluted in 50 mg of D5 or NS, infused over 10 to 20 minutes. And if the hypocalcemia is persisting, give us IV infusion of 10 ampules, that is 900 mg in 1 liter D5 over 24 hours. The other thing that we can give is calcium chloride. The problem with this is the more concentrated form. So we need a central line access. If giving, the dose is 1 gram. If giving peripherally, it is 2 to 3 grams and given slowly over 10 to 20 minutes. The problem with calcium chloride is if extravasation occurs, there will be local tissue necrosis. So that's why we usually go with the calcium gluconate. Other treatment, correct hypomagnesemia. And once the hypocalcemia is corrected, go for oral calcium 1 gram to 1.5 gram per day, along with vitamin D if required, 25,000 to 1 lakh units per day. Calcitriol can also be given. And nowadays, recombinant 184 parathormone in the form of NADPARA is also given for hypoparathyroidism. In case of vitamin D supplementation, if it is nutrition, it is 50,000 international unit, twice to thrice per week. And for malabsorption, it is 1 lakh units per day. Now we can go for case scenarios. So what I will do is I will read out the scenario, and if all of you can put the answers in the chat box, it's fine. Otherwise, you can unmute and speak. Or should I select? Should I direct the question to one at a time? Anything else? So let's move forward. A 40-year-old male presented with decreased appetite and vomiting. On examination, patient has pallor, acidotic breathing, HB was 7.2, creatinine was 1.9, SGPT 21, TSH bar free T4 3.2 bar 18, pH of 7.1 with metabolic with bicarb of 18, carbon dioxide of 33, sodium of 132, and potassium of 6.6. Patient was started on no doses and K-bind 1 week back. Now, on examination, patient has carpopedal spasm. So, what is the reason? What has happened? and how can we prevent it? So can everyone put their answers in chat box? Yeah, it is CKD related hypocalcemia, but the question was patient was having CKD with 7.1 pH, bicarb of 18, PCO2 of 33, phosphate of that potassium of 6.6. Patient was started on no doses and K-bind when patient had hypocalcemia. So what is the reason for it? I have explained the reason in the first slide. That's a clue. It's not PTH. PTH level is normal. Yes, Sanjeev sir has said correctly. We have to just, it's not right or wrong. Please participate. It's a learning experience. Yeah, Padma Kumar sir has said it is acidosis. Yeah, sir, can you unmute and say how this acidosis related thing can cause hypocalcemia in this case? Jomon sir has said hypomagnesemia correction, calcitriol supplementation. It's hypomagnesemia is not there in this case. Calcitriol supplementation is correct. Acidosis should increase calcium. So in this case, we have given no doses. That is soda bicarb, alkalosis. Bantu, Monica ma'am has said yes, alkalosis due to nodosis has caused hypocalcemia because there is shift. As I said in the first slide, if there is alkalosis, that is decrease in hydrogen ion, it causes the shift. And apart from that, the potassium binder is given, which will aggravate the alkalosis. So the nodosis is the culprit here. It has caused the hypocalcemia. And it can be prevented by, as Joman has said, calcitriol supplementation. So, well answered, guys. We can move forward with the next question. So, CKD patient nodosis, increased alkalosis should have added calcitriol. Next, a 28-year-old male with nephrotic syndrome was referred from nephrology OPD. Here, the patient does not have symptom. They have just referred because they have found the reports as hemoglobin of 9, creatinine of 0.7, SgO2 of 23, SGPT of 20, and calcium of 6.9. On further evaluation, phosphate was 2.5. So the normal phosphate level is 2.5 to 4.5. Normal PTH level is 10 to 55 because we will be using frequently in the coming case scenario. So we should know the normal value. So phosphate is 2.5, low normal range. PTH is normal. Vitamin D is 50 nanogram per ml. It's also in the normal range. Less than 20 we consider as vitamin D deficiency. And so what is the diagnosis? It's, yeah, Sai Krishna sir has said it is hypoalbuminemia. So can you explain, sir, more? Yeah, Jomund has said we need a albumin corrected calcium level. Albumin is not given in this scenario, but I have given a clue to the albumin in this scenario as nephrotic syndrome. So that's why if the corrected the thing was coming to be 6.9. So as we have said, it's hypoalbuminemia. So the albumin was required. So the albumin is found to be 1.5. So what is the corrected calcium? So 6.9 was the calcium in this scenario. 1.5 is the serum albumin. So can anybody put the calculate and put the answer? Yeah, the equation is correct. 0.8 is added, as Jomon sir has said, 0.8 should be added for every one albumin drop from 4. So I think it is coming to be 8.9. So the level was 8.5 to 10.5. So then level is normal in this scenario. As the Devika ma'am has said, yeah, right, Devika ma'am, it's 8.9. Usha ma'am has also said correctly. So next move to the next scenario. A 45-year-old female presented with weakness, irritability, perioral anesthesia. The female with irritability and perioral anesthesia with sodium of 132, potassium of 3.1, calcium of 7, albumin of 2.5, corrected calcium of 8.2, PTH of 32, vitamin D of 15, phosphate of 1.9. So what is the next step and what is the diagnosis? I think we should have more participation. I think I will suggest somebody to take up this question and speak. So can I select Monica ma'am? Can you take up this question? Monica ma'am, are you there? Dr. Mukund Rajta, can you take up this question? So I will lead this. Just go by the algorithm. First step is calcium is low. Check the corrected calcium. Ionized calcium is not there. It's okay, Monica ma'am. Thank you for attending. You can just type your answers at least. I came to know you are on duty. It's okay. You can put your answers in the chat box. So first step is calcium is low. Confirm the calcium levels. Corrected calcium came to be 8.2. Ionized calcium is not available. Next step will be checking the PTH. PTH is coming to be in the normal range. So we should go through which part of the algorithm. There are only two diagnoses in that. These two are just misleading points. It can be found as just added things. Yeah. Why magnesium? Because can Prabhu sir, can you just add some points? There is hypokalemia.
It, it,
Yeah, hypokalemia is there, and as well as hyponatremia is also there. There are other ion also decreased. So we should think of hypomagnesemia. So we have said one, if the PTH is coming to be normal, should think of hypomagnesemia and should correct magnesium first, then calcium. Otherwise, the patient will be having just continued hypocalcemia only. So thank you, sir, Prabhu sir, for your participation. So let's move forward. So hypomagnesemia, magnesium level. Next, an 18-year-old male who is obese, patient has decreased vision for of both eyes for 3 years. It is no, YERS years. Now presented with seizures. 18-year-old obese having vision abnormalities came with seizures. Calcium 7.2, albumin of 4, phosphate 9, create 0.4, PTH 200. Normal level phosphate 2.5 to 4.5, PTH 20 to 55. So by algorithm can yeah, how it is not CKD, create is 0.4. Vitamin D levels, we will it's coming to be normal. Yeah, Mugun, Dr. Mugun has said it is due to hypoparathyroidism. I said, so the presentation will be an obese person presenting with hypocalcemia and the phosphate is high. So phosphate high means it is due to non-parathyroid causes. So if the phosphate is high, we should look for creatinine. The creatinine is found to be normal. Then the most common diagnosis is due to hypoparathyroidism. Thank you, Mukund sir and Jomun sir has got it correctly. So they have got rightly as judo hypoparathyroidism. And the last case, a 62-year-old male with history of renal artery stenosis, which is recently diagnosed by a magnetic resonance angiography, was referred from OPD. Patient was asymptomatic except his BP was 180/90 and the lab finding were calcium was 4.4, albumin is 4, but on evaluation he has no Chostek or Trousseau sign. Phosphate is 3, normal range. Create is 1.8. There is mild increase due to some CKD part. PTH is 38, again normal. Vitamin D, normal. So it's a tricky question. Because there is some conditions that we will find the calcium as normal, but we should treat the patient, not the reports. So it is some kind of condition like that. So something is causing the calcium to become low. That's the clue. Any thoughts on it? Perfusion to the kidneys decreased by renal artery stenosis is there. So perfusion to the kidney is decreased. And in the CKD, to become from CKD, there will be hyperphosphatemia. So here phosphate is normal, PTH is normal, and even vitamin D is normal. So in CKD, usually there will be hyperphosphatemia. PTH will be initially increased, vitamin D will be decreased initially. Later, other points. Yeah, Sanjay sir has said low calcium level when it is very low without symptom, retesting is suggested. So the patient was again tested and found to have the same levels. So this comes to an important DD of spurious hypocalcemia. So here there is a clue has been given. The patient has undergone MRA. So in the MR angiography, we will give gadolinium. Gadolinium is one thing which will interfere with the calcium analysis, colorimetric analysis, and will cause spurious hypocalcemia, which will be very low. So when we think of the as algorithm part, if it is less than 7.5, we should give treatment, but the patient does not have symptoms in this case. So we'll be unnecessarily treating the patient and will causing hypercalcemia in this part if we does not consider the gadolinium part in the scenario. Another thing that we can look into is citrate. If we have taken, because some I have come across one case where the patient's ABG was taken from an EDTA tube. So the calcium, ionized calcium was found to be very low, 0.2. So in that case, we will be again rechecked and found to be again very low. It was because of the spurious hypocalcemia in that case. So we should think of these two DDs, gadolinium and taking BBG from an EDTA tube. So gadolinium induced spurious hypocalcemia. Now coming to the hypercalcemia. So here there are, if it is more than 10.5, it is hypercalcemia. But the ionized calcium more than 2.7 milliequivalents per liter. So there are various cutoffs are there. Means milligram, millimole, or milliequivalents per liter. So if it is milligram, it is more than 5.6. If it is millimole, we have said 1.31 or 1.4, take it as 1.4. If it is milliequivalents, 2.7. So mild, if we take it as mg per deciliter of total calcium, 10.5 to 12, moderate 10 to 14, and more than 14 as severe. Again, etiology we can classify as high PTH, low PTH. High PTH, so here there is excessive secretion of parathormone causing hypercalcemia and decrease in phosphate, as parathyroid is inversely proportional to phosphate. So in that holds good only in except in all the condition except tertiary hyperparathyroidism. So primary hyperparathyroidism is one of the conditions in excess PTH. It can be adenoma, hyperplasia, carcinoma. Then tertiary hyperparathyroidism, it is due to long-standing CKD causing increased PTH secretion. Then there can be ectopic PTH secretion and some familial causes like familial hypocalciuric hypercalcemia and lithium therapy. So we can think of, we can consider mnemonic as cleft, carcinoma, lithium, ectopic PTH, familial hypocalciuric hypercalcemia, and tertiary hyperparathyroidism. And if we consider the low PTH causes, mostly hypercalcemia patient coming will be mostly due to malignancy. So hypercalcemia of malignancy due to various reasons. We will come to that. The most common will be a PTH-RP, PTH related protein, which has similarity to PTH, 13 amino acid similarity to PTH. So it will cause increase in calcium and decrease in phosphate. And some lytic lesions like breast and myeloma. I have said osteoblastic bone formation will cause hypocalcemia, while lysis will cause hypercalcemia. Then excess vitamin D, as the vitamin D was the other hormone, due to intoxication, granulomatous disease like sarcoid and TB, lymphoma, increased resorption by hyperthyroidism or immobilization, increased calcium intake by total parenteral nutrition or milk alkali syndrome, other endocrine disorders like adrenal insufficiency, pheochromocytoma, VIPoma, drugs like vitamin E and D, estrogen, theophylline toxicity. So we should consider the important thing is adrenal insufficiency. So initially the presentation will be like patient will be having low normal hypocalcemia in adrenal insufficiency. But when the patient will be having low normal hypocalcemia, but when there is adrenal insufficiency, this hypocalcemia will convert to hypercalcemia. That will be the presentation. Initially, the patient was having low normal calcium, but now presenting with hypercalcemia, we should think of adrenal insufficiency. That's a clinical clue. So the causes can be mnemonized as thinking chimpanzees, thinking as thiazide, calcium supplementation, hyperthyroidism, immobilization, milk alkali syndrome, paraneoplastic PTH, adrenal insufficiency, neoplasm, Solinger-Ellison, excessive vitamin D and A, sarcoid and other granulomatous disease. Then hyperparathyroidism, secondary causing hypocalcemia with raised PTH and hypocalcemia, while primary will cause decrease in phosphate, tertiary increase in phosphate. Primary, there will be associated adenoma and sometimes associated with men neoplasia. And tertiary, usually associated with CKD. Familial hypocalciuric hypercalcemia is autosomal dominant, where there is PTH secretion is increased plus increased calcium reabsorption. So primary versus FHS, we have to look for fractional excretion and systemically scanned. In that, both of which will be increased, means we can find a source as well as increased excretion in this primary hyperparathyroidism. Because in the algorithm, there is, we'll come to that, why the differentiation is important. CKD, we can have both hypercalcemia and hypocalcemia due to various reasons. Hypercalcemia, the reasons can be due to prolonged disease, concomitant adynamic bone disease, excess calcium and phosphate, tertiary hyperparathyroidism, post-renal transplant, while hypocalcemia due to decreased vitamin D production, increased phosphate load, and secondary hyperparathyroidism. Malignancy, the reasons are PTH-RP, other is osteolysis and increased production of vitamin D. Clinical features, we can remember as back knee, bone pain, bones, groans, that mnemonic is there. So bone pain, arrhythmias, cardiac arrest, kidney stones, muscle weakness, and excessive urination. The patient will be confused with bone pain and kidney stones, will be having excessive urination. Other renal manifestation, it can cause diabetes insipidus, nephrolithiasis, and CKD. Most common cause of renal failure in sarcoidosis is nephrocalcinosis. So like previously, the first thing to consider is confirming the hypercalcemia in the step 1 of diagnosis, the repeat measurement, look for corrected albumin, look for correction with albumin, and if ionized calcium is available, we can go forward with it. And second step, determine the etiology like clinical clues like primary hyperparathyroidism, like if there is any family history of any malignancy, And lab evaluation, PTH, calcium, and albumin. So in case of a primary hyperparathyroidism, usually it will be a postmenopausal asymptomatic female, normal examination, and there will be family history of hyperparathyroidism and evidence of Men's syndrome. So Men's syndrome in type A causes primary hyperparathyroidism, where there will be pancreas affection, pituitary affection, and primary hyperparathyroidism. So there is in primary, there will be borderline or mild hypercalcemia. More than 13, we mostly will be malignancy associated one. The algorithm, after confirming, look PTH, if elevated, cleft causes, that is, we have discussed the carcinoma, lithium, and that cause. If it is minimally elevated, cleft causes, but we have to rule out FHS, familial hypercalcemic hypercalciuria. That's why the differentiation for fractional excretion of calcium and the systemic BP scan. That's for minimally elevated PTH. That condition we should consider this. But the broader differential will go for low normal to normal PTH, where we will think of the chimpanzee's causes. In that, we'll first rule out humoral hypercalcemia malignancy using PTHRP. If it is elevated, if no, we'll go for 125 vitamin D. If it is elevated, granulomatous causes like sarcoidosis, TB, and lymphoma. If again is not there, we'll go for calcidiol, that is 25 hydroxyvitamin D. Can be vitamin D intoxication. That is also negative. For electrophoresis, electrophoresis has found something, CRAB criteria, multiple myeloma. If not, look for other evidence like vitamin A intoxication, hyperthyroidism, theophylline toxicity, etc. So the other test will be serum phosphate, depending upon the parathyroid, whether it is related to if it is low, it will be hyperparathyroidism, hypercalcemia malignancy, elevated in vitamin D, and urinary excretion of calcium, most commonly important in FHH diagnosis. So therapeutic management, less than 12, does not require any treatment. In case of severe and moderate with symptoms, we need treatment. The treatment will be volume expansion using isotonic saline 200 to 300 ml per hour to have a urine output of 100 to 150. So if we get 200 to 300, the half of which should be having as the urinary output. That we should target like that. But we should avoid the loop diuretic except in the cases of renal or heart failure. We can also use calcitonin in this case, which was the third hormone, 4 units per kilogram IM or sub-Q. If we have got a hypocalcemic response in the 4 to 6 hours, the patient is calcitonin sensitive, so we can repeat as 12-hourly dosing for 24 to 48 hours. The response is not satisfactory, increase the dose and see for the calcitonin sensitivity. Bisphosphonate, consider two things, that is vitamin D and creatine level should be checked, because hypercalcemic vitamin D deficiency, if we give bisphosphonate, there will be hypocalcemia, which is very severe. And creatine, if it is increased, it should be bisphosphonate should be given at a lower dose. So the various bisphosphonates are zoledronate, amidronate, ibandronate. It will have osteonecrosis of the jaw, flu-like symptoms. So we should consider adequate hydration and lower dosing, slow infusion in renal impaired. Other options are denosumab in case of bisphosphonate refractory, or in case of bisphosphonate is contraindicated. We can also go for gallium nitrate, which is used for malignancy related hypercalcemia. And there are some ongoing studies on mitramycin or plicamycin, which is a cytotoxic antibody from the embryonal tissues. And if nothing is working, go for hemodialysis. So Now we can just brush up our algorithm. So coming to the scenario, 16-year-old male presented with bone pain. Here calcium is 14.4 increased, phosphate is 4.4, means it is in the high normal range. So hypercalcemia, then PTH is less than 1. So it is decreased. Hypercalcemia, decreased PTH. Vitamin D is 15. Calcitriol is 10. With X-ray, there is lytic lesion. Yeah, it is malignancy related. As Joman sir has said, malignancy, yes. Because as like we have considered, hypercalcemia, go for PTH level, PTH is low, go for PTH-RP, which is not available here, but we can go for the other parameters like X-ray, there is a lytic lesion. So the diagnosis is in a 16-year-old with malignancy, there was some ALL, means malignancy was there. So coming to the next scenario, a 46-year-old male presented with increased hunger, tremors, anxiety for 8 months. Please look carefully this scenario. A 46-year-old female presented with increased hunger, tremors, anxiety, dizziness for 8 months. Her random blood sugar was 35. It was reversed with the D50. Patient has history of recurrent renal stones. Her calcium is 13. PTH is 210. PTH normal level is 20 to 55. So at least can you write, can you say the differentials? Yeah, it comes in the cleft pneumoniae, carcinoma, adenoma, lithium, ectopic, FHH, tertiary. So which one of it is looking? So postmenopausal, around 46 years, perimenopausal age, female, presenting with increased hunger, tremor, dizziness. So there is some form of decreased steroids. So some pituitary affection, RBS 35 reverse with D50. Some pancreas is also affected. Recurrent renal stone. So there is long-term hypercalcemia. So pituitary, pancreas, and parathyroid. Which among the primary hyperparathyroidism? Yes, Usha ma'am has said many. So just from the two tests and the clinical history, we have got the diagnosis. So this Menet syndrome and the treatment is near total parathyroidectomy we should consider, apart from the other carcinomas. So the next is a 28-year-old male presented with abdominal pain, frequent urination, and dysuria. So here the calcium is 14, so it is raised. Phosphate is 7, again 2.5 to 4.5 normal level, it is raised. PTH is 3.4, 20 to 55 normal, it is reduced. So which is the next step? So we have gone for calcium, PTH is low. So we go for the differentials of chimpanzees. So get from the chimpanzees, the first what we look is PTH-RP. later calcitriol, then calcidiol. So here the calcidiol is 134. Yeah, PTHRP is normal or it is undetectable. Calcitriol is normal, but calcidiol is 134 elevated. So here the patient has recurrent urination and dysuria. Vitamin D is elevated. So can you just correlate high calcium, increase phosphorus, reduce PTH? Yeah, Joman sir has said vitamin D supplementation. Sorry. And Usha ma'am has rightly said vitamin D toxicity or hypervitaminosis is the diagnosis causing nephrocalcinosis. That is increased urination and dysuria.
Sir, one doubt. Why was the calcitriol normal?
Because there is external calcium supplementation work there in the form of calcidiol.
No, sir. You mentioned that calcitriol is normal and diol is 134.
Yes, because calcitriol usually will be elevated in granulomatous conditions, and the vitamin D, if it is elevated, that in the case of hypervitamin, it will be calcidiol mostly. In this case, it was found to be normal. I have just come across this. This case has come to our emergency last week only. So I was also curious, but eventually it was fitting in the diagnosis. He was just taking that calcidiol as the supplementation.
Got it, sir.
Yeah. Thank you, Usha ma'am, for the nice query. So a 40-year-old female with history of weight loss of appetite for 6 months, presented with abdominal pain, headache, high BP, calcium 13.5, which is increased, phosphate is 7.5, PTH is undetectable, and 25 hydroxyvitamin D is normal. And here the calcitriol is high. I think Usha ma'am must have got the diagnosis first in this scenario.
Yeah, TB or sarcoid.
Yeah. Here, vitamin, weight loss appetite, everything is there. So granulomatous condition, mostly TB holds best in this scenario. And we should go for a CB-NAT test. And the last scenario, a 55-year-old female presented with progressive alopecia, weight loss over months. This is very interesting case. There was severe weakness, arthralgia, myalgia, bone pain. On examination, alopecia with smooth, shiny skin with orange tinge. And there was dermatitis. Calcium was 15.4 elevated. Phosphate was 5.9 elevated. PTH was 556 is less. So next step will be looking for PTHRP, which is undetectable. Vitamin D normal. Urine and electrolysis normal. Thyroid function normal. So we have reached the end of the algorithm. So can somebody say how will we proceed in this case? There was enough clue in the scenario. The patient is having progressive alopecia, smooth shiny skin with orange tinge, and there was dermatitis. So toward the end of the algorithm, there is only two courses mostly we'll be considering. So can anybody say that? Skin condition, anything that we put on face for acne.
Retinoic acid.
Yeah, it's vitamin A toxicity.
Okay.
Vitamin A was found to be 471 in this case. That's vitamin A toxicity. So thank you all for your energetic participation in the case scenarios. I know this was a dry topic, so I was trying to make it more interactive by adding some case scenarios. Thank you all for your wonderful participation. And thank you, Ashima ma'am and Sanjeev sir. Anything to add, Sanjeev sir?
I can just say words of thanks for you and for
Thank
the
you, sir.
active participation of the participants like Dr. Lusa, Dr. Juman. And this is how we teach and learn with each other.
Yes, sir.
A fantastic presentation, particularly with the addition of case scenarios. It cleared a lot of concepts of everyone. So thank you very much again.
Thank you, sir. Usha ma'am, can you, is there any other faculty over here?
No, sir, all students. Only OP, sir.
Okay, thank you. I miss Miss Ashima ma'am in the presentation. So anyway, thank you all.
Okay,
So,
let's wind up.
okay, thank you.
Thank you, everyone.